All right, today we're diving into a really tough opponent in the clinical lab, Burkholder multivorans. This is one of those pathogens that really tests us from identification all the way to treatment. We've put this brief together using Gemini Deep Search, and if you want to dig into the primary sources, you can find them all in the linked notebook. So let's get right into it.
First things first, we need to be crystal clear about the stakes here. With Burkholderia multivorans, they are incredibly high. This is the absolute worst-case scenario, Cepacia Syndrome. We're talking about a rapid, destructive, and all too often fatal pneumonia. It's a stark reminder of why every single step we take in the lab is just so critical.
Okay, so let's start by really defining the problem. Who exactly is this organism targeting, and what does an infection actually look like from a clinical standpoint?
So, the basics, we're looking at a gram-negative, non-fermenting rod. Now, the really key thing here is its membership in the Burkholderia Cepacia complex, or BCC. You might know it by its older name, Genomovar 2. This complex is a group of over 20 species that are phenotypically almost identical. And, that similarity is exactly where so many of our diagnostic headaches begin. This is a classic opportunist. When we think of this bug, we almost always think of patients with cystic fibrosis, and for good reason. But it's also a major threat for people with chronic granulomatous disease and really any other immunocompromised patients. And critically for us in the hospital setting, it's a well-known cause of nosocomial outbreaks. And these outbreaks can be traced back to some pretty surprising sources, things like contaminated non-sterile products or even the hospital's own plumbing.
All right, let's put ourselves on the bench for a minute. A specimen from one of these at-risk patients shows up in your lab. Let's walk through that whole identification journey, from the moment you streak the plates to getting that final molecular confirmation.
So what are the clues we're looking for? Well, it's a gram-negative rod, it's oxidase positive, and it's motile, standard stuff. But there are a few distinctive features that should really make you start thinking BCC. That earthy kind of dirt-like smell is a classic tell. On a McConkey plate, it's a slow lactose oxidizer, so you'll see those pink or red colonies, but it can take 4, 5, even 7 days to show up. And of course, it'll grow in selective media like Burkholderia Cepacia selective Agar, or BCSA.
But here's the kicker. All those clues on the bench, they'll get you into the ballpark of the Burkholderia Cepacia complex, but they will not reliably get you a species-level ID of Burkholderia multivorans. The members of this complex just look too much alike on the plate. And why does that matter? Well, that species-level distinction has massive clinical implications.
And this brings us to an absolutely non-negotiable point. You have to go molecular. Sequencing the recA gene is the gold standard, period. It cuts right through all that phenotypic noise and gives you the clear, unambiguous species-level ID you need. And the reason this is so critical can literally be a matter of life and death. A patient with Burkholderia multivorans might still be eligible for a lung transplant. A patient with, say, Burkholderia cepacia often isn't. The identification your lab reports can directly impact a patient's access to that kind of life-saving treatment.
Okay, let's switch gears to the next major challenge, antimicrobial resistance. With this organism, it's not really like fighting a simple bug. It's more like trying to lay siege to a fortress.
This bug has this incredible multi-layered defense system. First, its outer membrane is tough to get through. It has reduced permeability that acts as a physical barrier. Second, for any drug that does manage to sneak inside, the bacterium has an arsenal of efflux pumps ready to actively kick it right back out. And third, if a beta-lactam makes it past those first two defenses, the organism has chromosomally encoded beta-lactamases just waiting to chew it up. It's a really tough nut to crack.
And this isn't acquired resistance we're talking about. This is baked right into its DNA. It's intrinsically resistant to polymyxins like colistin, which is why our selective media works, and it's also resistant to aminoglycosides. But what's really alarming from an infection control perspective is its resistance to common hospital disinfectants. We're talking chlorhexidine and quaternary ammonium compounds. That hardiness is a huge reason why it can be so stubborn in the healthcare environment.
This quote just nails it. The very same biological tools that let this bacterium survive in tough, nutrient-poor places like soil or a hospital sink drain, those are the exact same tools it uses to fight off our antibiotics. Its environmental toughness and its clinical resistance are really just two sides of the same coin.
So, all of this brings us to a huge problem for both the lab and our clinical colleagues.
How on earth do you treat an infection when the main tool you rely on for guidance, the antibiogram, is fundamentally unreliable?
And this is where you see a major split between the big international bodies. On one hand, you have EUCAST, the European group, and they're very clear. Routine AST should not be used to guide therapy. Why? Because the results aren't reproducible, and more importantly, they just don't correlate well with how patients actually do. Then you have CLSI in the US, which has historically published breakpoints, but even they've noted ongoing performance issues. For a clinical lab, that's an incredibly tough position to be in.
So that leaves us with the million-dollar question, right? If you can't fully trust the MICs to predict what will work in a patient, how are clinicians supposed to make good treatment decisions?
Well, the answer is you have to rely on empirical protocols that are built on clinical evidence and years of experience. This is a fantastic example from a Dutch CF center designed for outpatient eradication. And look at the logic, it's so smart. You have inhaled amiloride for potential synergy, inhaled tobramycin to get super high concentrations right in the lungs to overwhelm resistance, and then oral cotrimoxazole for systemic coverage. It's a thoughtful, multi-pronged attack that doesn't just hinge on a single MIC value.
And that idea of a multi-pronged attack is really the name of the game internationally. For any severe infection, the consensus is clear: aggressive combination therapy. Monotherapy is a big no-no. The strategy is to use at least 2 active drugs, optimize their dosing with things like high-dose extended infusions for carbapenems, and even look to newer options like ceftazidime avibactam for those really tough refractory cases.
Now, when you're talking about kids with CF, the approach gets even more aggressive. And you can see here, the primary goal isn't just to treat an infection, it is to completely eradicate it. The whole idea is to hit this bug hard, right when it first appears, to stop it from ever setting up a chronic, lifelong infection. And that often means using higher, weight-based doses of key antibiotics to account for the different ways these drugs move through a CF patient's body.
So if identification is complex and treatment is a minefield, where does that leave us? Well, it brings us to what is without a doubt our most powerful weapon in the fight against Burkholderia multivorans: infection prevention and control.
Because this organism can spread so easily between CF patients, the IPC rules have to be absolutely ironclad. We're talking strict physical segregation in clinics and hospitals, counseling patients to avoid social contact with each other, and using dedicated medical equipment for every single patient, down to the last stethoscope. And of course, regular surveillance cultures are key to catching any new acquisition early so you can break that chain of transmission.
And it's not just about patient-to-patient spread. You have to think about the entire hospital environment as a potential reservoir. We've seen outbreaks linked to something as simple as contaminated tap water or ice. It means keeping a close watch for contaminated non-sterile products and, maybe most importantly, having a really robust water management program to control the risk right at the source, the hospital's own plumbing.
Look, this is a tough bug, and the science is always moving. If you found this useful, please do us a favor and subscribe to the channel. We'd also really love to hear from you. Let us know your thoughts, and if you have local protocols or best practices that work for you, share them in the comments below. Let's learn from each other.
And that leaves us with a final, big-picture question to chew on. For a pathogen this adaptable, this naturally resistant, and this difficult to treat, are we putting too much focus on therapy after the fact? As resistance continues to evolve, maybe aggressive, relentless prevention isn't just one part of the strategy, maybe it's the only truly sustainable one we have. Something to think about. Thanks so much for watching.